For our next session on first-line pharmacotherapy for MASH, we would like to invite on stage our moderators, Dr. Ashish Kumar, Dr. Jay Toshniwal, Dr. B.R. Medhi, Dr. B.C. Sharma, and our chairpersons, Dr. A.D. Khilji, Dr. Satyarth Chaudhary, Dr. Bhagwan Singh Thakur, Dr. Arun Kumar Singh, and Dr. Vineet Shah. We would also like to invite on stage Dr. Sanjay Satpathy and Dr. Abraham Koshi. For our first talk on PPAR agonists, we would like to invite on stage our speaker, Dr. Sunil Dhadij.
Good morning. At the outset, let me thank Dr. Arora sir, Dr. Ashish and Praveen for giving me this opportunity. And after lifestyle changes, I think we are going on for a pharmacotherapy for MASLD. And my job is to convince you for PPARs. So why use PPARs in MASH therapy? PPARs, basically peroxisomes, are derived from endoplasmic reticulum. And they are basically initially called as microbodies, and they are involved in respiratory system based on the hydrogen peroxide, and they are basically a source of or a site for beta oxidation of fatty acids. Proliferation of these peroxisomes is mediated by the peroxisome proliferator activated receptors. So the PPARs are the one who activate peroxisomes, and in peroxisome they in turn activate the fatty oxide metabolism. And these PPAR receptors belong to nuclear receptor family of activated ligand activated transcription factor. There are three types of receptor: alpha, beta, also known as delta, and the gamma receptors, and they can be stimulated by pharmacological agents, and also there are natural agonists. They are basically lipid sensors, and they are activated by in a normal person by fatty acids and also by the pharmacological agonist, and they modulate the gene expression in the given cell, in the given tissue or cell, where they enhance the fatty acid metabolism. In a way, it induces the metabolic flexibility in a given person. And they express their action by trans-activation as well as trans-repression. There are three types. PPAR alpha is located mainly in the liver, heart, and skeletal muscle. It's being a lipid sensor, increases the mitochondrial oxidative metabolism. They're also the downstream pathway for FGF21. Remember this. Delta is basically located in the skeletal muscle, also in the liver and the cells, and it promotes the muscle metabolism from glycolytic to the oxidative pathway and improves the muscle utilization of fat and utilization of glucose also. And PPAR gamma is basically located in the adipocytes, helping the differentiation and the metabolism of fat in these adipocytes. So just to summarize, these alpha, beta, and the gamma: alpha mainly for liver, gamma mainly for adipocytes, and the beta is it. So as we know, the multi-hit hypothesis of NASH, it is based on multiple factors: increasing dietary intake or increasing fatty acid influx from the adipocyte into the liver, lipotoxicity, mitochondrial degeneration or destruction of hepatocytes, and the inflammation. And the PPAR pathways are involved at least almost all the steps of this multi-hit hypothesis of NASH pathogenesis. So PPAR are the ideal compounds to be used for MASH therapy. What are the agents? PPAR can be single agents. Like alpha, you have fibrates. Like gamma, you have thiazolidinediones. And for delta, mono agonist or the single agonist is say sildenafil. The dual agonists are elafibranor for alpha and beta, and the saroglitazar for alpha and gamma. And we also have a pan-PPAR, which is lanifibranor. I'll just go for the clinical evidence. This is the first proof of concept trial using pioglitazone. Biopsy-proven NASH, 6 months of pioglitazone along with diet changes, and there is significant improvement in biochemical parameter as well as the histological parameters. Later on, there was a randomized control trials, again pioglitazone versus placebo, and there is significant improvement in liver-related as well as the biochemical pathways. And the conclusion was there is significant improvement in metabolic and histologic parameters. Then comes the P1 trial, the classical trial, we all know about it. The vitamin E, pioglitazone, and placebo, although pioglitazone could not reach the primary outcome of histological improvement, vitamin E could reach, but the dose of pioglitazone used in this trial was only 30 milligram. Later on, there was another randomized control trial using the 45 milligram of dose of pioglitazone, which has shown a primary outcome in around 60% of patients. And then there is a meta-analysis of 8 RCTs, 5 with pioglitazone, 3 with rosiglitazone. We don't talk about rosiglitazone because it's already out of market. All outcomes, the diamond is on the right, on the positive side for pioglitazone. Even in patients with advanced fibrosis, pioglitazone is very effective in reversing this. So pioglitazone improves advanced fibrosis in NASH even in patients without diabetes. The only side effect is weight gain, which is now being taken care of by use of the R-enantiomer of pioglitazone. Studies are underway where it is found to be equally effective without weight gain. Coming to saroglitazole, our own compound, this is a real world evidence, 18 studies, 5 published, 13 abstracts, around 6,000 patients. And there is improvement in biochemistry, especially the lipid profile, AST, ALT, and there is improvement in fibroscan values in patients who have MASLD. This is a phase 2 trial published in Hepatology. 106 patients. Saroglitazole used in 1, 2, and 4 milligram doses. Primary efficacy was change in ALT level and the liver fat content as shown by MRPDFF. And there is a significant reduction, more than 30% reduction in significant number of patients using saroglitazole 4 milligram. And there is significant reduction in the triglyceride levels in these group of patients. So it has been found to be very effective. This is a very short study from Ganga. 3 months sorrow, and those who lost weight had received the improvement. Another study from our country, there is improvement in fibroscan values as well as the blood parameters using saroglitazole for 12 months. Coming to lanifibranor, which is a pan-PPAR, a landmark trial published in NEJM. Pan-PPAR phase 2B double-blind randomized placebo-controlled trial, 2 doses, 800 and 1200 milligram. And 1200 milligram achieved almost all the primary as well as the secondary outcomes. And so this has been found to be very effective in reversing the histological changes in patients with NASH. The phase 3 trial is already on. The inclusion are already completed. Probably will get the results by next year. There are counterproductive PPARs. One of them is elafibranor. Initial golden trial showed positive effect, but later on resolved out IT trials. The phase 3 trial did not show significant improvement. So the drug is no longer used in these group of patients. There are few other counterproductive PPARs like the fibrates and the rosiglitazone and the seltamab. So why use PPARs because NASH is not a disease in isolation. There are cardiovascular effects of NASH. Dr. Anand has discussed in very detail. So if we can't treat NASH in isolation, so drugs which has got a effect both on liver as well as the cardiometabolic risk factors are preferred over the others. The PPAR alpha has got all effect against the prevention of cardiometabolic risk factors, delta against few, and the gamma against also few of the risk factors for cardiometabolic risk factors. But at the clinical evidence, the PPAR gamma agonist pioglitazone already has shown effect in the prevention of cardiometabolic risk factors. And the meta-analysis on saroglitazole, again, 7 randomized control trials has shown a very effective reduction in these abnormal lipids as well as the other parameters which increases the risk of cardiometabolic. Another pooled analysis of multiple trials shown a reduction in these bad fat levels in these group of patients where the saroglitazole is used. The newer pan-PPAR agonist lanifibranor, this is the secondary analysis of that non-native trial which I discussed earlier. Again, it has shown there is a significant reduction in liver fat as well as the blood lipid parameters, including insulin resistance, blood pressure, and steatosis. A latest study on PPAR 25 again shown almost similar effect compared to, as shown by the native study. So the purpose of debate is to find out the first line pharmacotherapy for MASH and what is an ideal pharmacological agent for MASH. Recently, there is an letter to editor by Ashish saying that there is a ceiling effect of all individual drugs in the patient with NASH, where the effect of individual drug is not up to a particular mark. So you need combination rather than celebration. So what combination do you need? You need a combination of drugs which can have anti-steatotic, inflammatory or fibrotic pathway. And look at our compound. PPAR has got effect on steatosis, inflammation, as well as the fibrosis pathways, as well as the extrahepatic pathways, liver, adipocytes, and all others. So PPARs are effective across all spectrum of NFL, NASH, as well as fibrosis. So ladies and gentlemen, given the complexity of NASH pathogenesis, there is a great interest in the development of combination therapies targeting different aspects of the disease. The PPAR regulate pathologically affected pathways in NASH, making them attractive therapeutic options. And ongoing trials have shown their effect both in liver as well as the extrahepatic outcomes. So rather than looking for a combination, go for a well-designed PPAR which is effective in all these disorders. Thank you very much.
Thank you, Dr. Sunil. Now for SGLT2, I would like to invite Dr. Amit Mandot to have his take on the other drug as a first-line therapy for the MASH.
Thank you, Dr. Ashish, and thank you, Professor Arora, Praveen, and Dr. Ashish. I didn't know this is a debate, but I'll present the data on SGLT2. But this is a fantastic concept actually to discuss all the drugs. Yeah, so SGLT2 inhibitors in MASLD, we all know sodium glucose co-transporter inhibitors. These were initially developed for type 2 diabetes management, and there are drugs like empagliflozin, dapagliflozin, canagliflozin. So canagliflozin acts on both SGLT1 and 2, not very selective, but DAPA and EMPA are SGLT2 selective. So what it does is it inhibits renal glucose reabsorption at the level of renal tubules, and that is how there is glucoseuria. Almost to the tune of 47 milligram per day, there is glucoseuria. So obviously the sugars go down and it will lead to glycemic control. Weight reduction is very modest. I will come to the data, and it reduces blood pressure. So it was definitely very useful from the cardiovascular and renal point of view. But once the studies came up, we realized that there are a lot of hepatoprotective mechanisms which SGLT2 has to offer. So it reduces hepatic steatosis, inflammation, and fibrosis. How? It increases fatty acid oxidation, de novo lipogenesis is reduced, and reduction in oxidative stress is there. What it also does is there is a macrophage polarization. M1, which is predominantly pro-inflammatory, is converted into M2 type of macrophages, which is anti-inflammatory. So reduces inflammation, and there is reduction in fibrosis, apart from the systemic effects. So coming to, I'll just present two very important meta-analysis, so for want of time. This one, so basically the landmark trials have been the EMPA-REG outcome, CANVAS, and the DECLARE-TIMI. And this has taken into account all the basic pathologies which are associated with MASLD. So this is one large meta-analysis of real-world data, which I found is very interesting. This was published in July 2025. This is all, so basically TriNetX is a data platform where you get all the data, and there were 38,000 patients were studied. Those who were exposed to SGLT2 and those who were not exposed to SGLT2. So almost 19,000 patients in each group. Advanced liver disease at baseline or those with liver cancer or transplant were excluded, and they were propensity score matched based on demographics, comorbidities, and labs. So just go through this data. The ALT and AST level, definite reduction, p-value is significant at both 5 and 10 years. I have highlighted the 5 years data here. So those who were exposed had ALT of 38 versus 45 in unexposed, AST of 29 versus 34, ALP 80 versus 85. So we know that reduction in AST-ALT is a kind of one of the markers of reduction in steatosis. So that's one parameter. Platelet count showed marginal reduction. HbA1c obviously was better because the main effect is anti-glycemic. The BMI reduction was very modest. So here it would probably be inferior to GLP-1 agonist. The reduction in weight is there, but just to the tune of the BMI reduction by 1.5. Most important is the cardiovascular events, where it really scores, and as we discussed previously, A lot of these patients have cardiac comorbidities, and there is a definite reduction in cardiovascular events at 5 years and 10 years. And there is reduction in advanced liver disease outcomes. So what this study had done is compare the clinical outcomes, the laboratory outcomes, and the requirement of drugs. Across all these three important parameters, there was a reduction in the patients who were exposed to SGLT2. So there was a reduction in any advanced liver disease by almost, it was 7% in SGLT2 exposed versus 15% in unexposed patients. So yes, in real world data, it shows reduction, it shows benefit when it comes to advanced liver disease outcomes. Most important, mortality. So 10-year data, because we should look at a long-term outcomes, and the 10-year mortality, there was 1% in those who were exposed and 3.75% in those who were unexposed. So almost a 72% reduction in all-cause mortality, and that is where I think SGLT2 has a very important role to play. So the real-world impact, to summarize, 10 years follow-up, reduction by all-cause mortality by 72%, reduction by 52% in advanced liver disease, and definite reduction in cardiovascular events. Coming to what it specifically does to fibrosis and steatosis, this is another important meta-analysis which focused only on steatosis and fibrosis. So liver-related outcomes, these were 18 trials, all were randomized controlled trials, and they specifically looked on, and of course, these were different parameters. Some used MR-PDFF, some used FibroScan, some used histology, and they compared the steatosis and fibrosis. And what it found is that the mean difference in the steatosis, the cap values, there was a reduction by 10 dB per meter in those who were exposed to SGLT2 or those who took SGLT2. And most of these patients received drug for almost between 12 to 48 weeks. When it comes to fibrosis, the liver stiffness, there was a reduction by 0.67. So just about 0.67 reduction in liver stiffness across all these trials, 18 trials, which had studied steatosis and fibrosis. So there is a higher likelihood of at least one score or one stage reduction than the control group, specifically with respect to hepatocellular ballooning and liver fibrosis. There was no difference between the two groups when it came to the changes in steatosis or lobular inflammation. So ballooning reduced, the fibrosis reduced. This meta-analysis did not show any specific benefit when it came to steatosis. So this is again the summary of these 18 RCTs. There was a reduction in CAP. 6 trials had specifically looked at that. There was a bit improvement in liver stiffness, liver splenic stiffness ratio. 3 trials had looked at that. MR-PDFF, 5 trials found benefit in favor of SGLT2 inhibitor. When it came to histology, there was no significant difference in steatosis or lobular inflammation. Fibrosis, there was a modest reduction in liver stiffness measurement. But again, low to moderate certainty of evidence because these were small studies, heterogeneous group, and there was a lot of confounding bias. So the strengths, limitations, and future directions of SGLT2. When it comes to the real world data, we have a huge real world cohort of almost 40,000 patients with 10-year follow-up and consistent outcomes across all the benefits across all the parameters. Limitations were all these were observational studies, retrospective, lot of confounding. There was no biopsy of fibrosis staging. So there will always be some doubt when we analyze these data. So the future research could be head-to-head trials, combination therapy with genetic subgroup analysis, and MASLD without diabetes. 10% of this real-world data were non-diabetic. How does it compare with other MASLD therapy? Lifestyle modification is always cornerstone, but we know adherence is difficult. Pioglitazone improves histology, but it increases weight. Resmetirom, limited cardiovascular benefit or cardiovascular data. GLP-1, definitely very, very important agent, strong efficacy, strong cardiovascular benefit. There may be a potential synergy with SGLT2 inhibitors. SGLT2, liver and cardiovascular, we have real-world evidence that it is useful. So to summarize, this is my last slide. It reduces steatosis and fibrosis, improves liver enzymes. It is a definite adjunct to diet and lifestyle, and an alternative to pioglitazone and GLP-1. But small trials, mostly Asian cohorts, moderate heterogeneity. So right now, it cannot be generally It cannot be, it has limited generalizability when it comes to treatment only for MASLD. I thank you for your kind attention.
Thank you, Dr. Amit. Now we heard the 2 established drugs. Now 3 new drugs for Resmetirom. I'll like to invite Dr. Arkade to give his talk on Resmetirom.
Thank you, sir. Thank you to Dr. Arora, Dr. Ashish, and Dr. Praveen for the kind invitation. And my task in the next 8 minutes is to convince you that Resmetirom may have a role as first-line pharmacotherapy for MASH. So as we all know that MASLD is one of the commonest chronic liver diseases, and the central pillar of management is lifestyle interventions with the target of achieving weight loss. But this weight loss is difficult to attain and even more difficult to sustain, and there has always been an unmet need for MASH-specific pharmacotherapy. And Resmetirom was the first drug to get an accelerated approval or a conditional approval by FDA in 2024 for MASH with F2, F3 fibrosis. Now, before I move on to Resmetirom, since this is a debate, 2 points I would like to make about the PPARs and the SGLT2 inhibitors. First, about the PPARs, single-arm trials have no meaning in a disease like MASLD, which has got such a huge placebo effect. And a meta-analysis is only as good as the included trials. So we really need phase 3 trials, phase 3 RCTs with both saroglitazar or lanifibranor for that matter, before we can call it as first-line therapy, in my opinion. With respect to the SGLT2, Dr. Amit has already shown you all the real-world data and the meta-analysis, etc. But I think one point again in favor of the SGLT2 inhibitors would be that there is a recent phase 3 RCT which has just been published in, I think, BMJ on dapagliflozin, which shows that it improves both histologic MASH resolution as well as fibrosis. So Resmetirom, the big thing about what is the premise of Resmetirom is that MASH is a state of intrahepatic hypothyroidism, even if the systemic thyroid levels are normal. And this is because normally T4 is the pro-hormone which gets converted into T3 with the help of deiodinase 1 enzyme. But when the liver is injured, the deiodinase 1 gets suppressed, and therefore the T4 gets more preferentially converted into reverse T3, which is biologically inactive. And this is what Resmetirom should help correct. Very important point to note about Resmetirom is that the mechanism is liver specific. This is because the thyroid hormone receptor beta is present primarily only in the liver. And unlike the other drugs that we are discussing today, its mechanism is primarily via hepatic lipid metabolism and mitochondrial bioactivity. So this is one of the drugs that is affecting the hepatic lipids. And it does this by decreasing de novo lipogenesis via the SREBP mediated pathway. And as well as the cholesterol that is already in the liver, it increases the breakdown of the cholesterol by enhancing CYP-A7. And it also increases mitochondrial bioactivity, increases mitochondrial biogenesis, decreases mitophagy, and leads to increased free fatty acid oxidation, ultimately net resulting in decreased intrahepatic lipids. Now, these are the FDA, or for that matter, the European Medical Agency efficacy endpoints. We either want MASH resolution without worsening of fibrosis, or improvement in at least one stage of fibrosis without worsening of MASH. And this is the phase 3 RCT with Resmetirom, the MAESTRO-NASH trial. Now, 966 patients into 3 arms, but the point to note here is that 33% patients were diabetic, and while GLP-1 analogs, pioglitazone, etc. were not allowed to be introduced in the preceding 6 months, however, if the patients were already on stable doses of these drugs, they were allowed to continue, and you have a separate subgroup for that. So overall, what this phase 3 RCT shows is that Resmetirom showed significantly better resolution of MASH without worsening of fibrosis to the tune of around 25 to 30%, and improvement in fibrosis by one stage without worsening of MASH, and that was also significantly better, around 25%. The secondary endpoint improvements was also important. There was changes in the significant improvement in ALT, AST, GGT, in the MRPDFF, but very importantly in the lipid profile, in the atherogenic lipid profile. So LDL, apolipoprotein B, lipoprotein A, all of which are very important with respect to cardiovascular events. All of these lipids significantly improved with Resmetirom at the end of 54 weeks. Of course, at the end of 52 weeks. Of course, the final clinical outcome data at the end of 54 months is much awaited, and that would be the final, I think, the proof of the pudding. This slide is also very important. Data from the Maestro-NASH trial shows that Resmetirom can improve health-related quality of life. And I think from the patient perspective, health-related quality of life is possibly a very, very important factor for a disease in F2, F3 fibrosis stage in which it is not very advanced and would be relatively innocuous to the patient from the symptom point of view. So Resmetirom resulted in improvement of the CLDQ, NAFLD, and various domains of the liver disease quality of life questionnaires at 24 and 52 weeks. Those who responded to Resmetirom had a better improvement in quality of life than those who did not respond to Resmetirom. And as such, in the placebo group or Resmetirom non-responder group, there was no improvement in quality of life. And the best improvement in quality of life was those patients who had baseline F3 fibrosis. Adverse effects of Resmetirom, because it is a liver-specific drug, the adverse effects, systemic adverse effects, are expected to be minimal. And as such, the most common adverse effect was diarrhea. This was seen in around 30% of the patients. But in 50% of the patients, this was actually reported as worsening of pre-existing diarrhea. And the median duration for which the diarrhea lasted was only around two weeks. And no serious adverse events have been reported or major adverse cardiovascular events with the use of Resmetirom. We obviously have a lot more data with the GLP analogs, with SGLT2 inhibitors. And mind you, even though the trials would not find it, we now know that there are serious adverse events with GLP analogs. For instance, non-arteritic ischemic optic neuropathy or NEON, which is untreatable visual loss. With the SGLT2 inhibitors, we can have non-diabetic ketoacidosis, increased risk of gangrene, ischemia, etc. All these. But these are not expected with Resmetirom because it's a liver-specific agent. We obviously have some ASLD guidance, so this would be clinically useful because we at least have some guidance as to how to select the patients, how to follow it up with Resmetirom. So this is my critical appraisal of Resmetirom vis-a-vis the other possible pharmacotherapeutic agents that we have for MASLD. Number one, it's a liver-specific drug. It primarily affects the hepatic lipid metabolism and mitochondrial bioactivity. And if you remember when we used to talk about the 2-8 hypothesis, it is the accumulation of fat in the liver in the first place, which is resulting in MASLD. And even in the multi-8 hypothesis, accumulation of fat in the liver in the first place would be required for MASLD to go on. So the fact that it affects the intrahepatic lipid metabolism could be an advantage. There's composite histologic benefit for both steatohepatitis and fibrosis documented in phase 3 RCT. There's consistent signals of the non-invasive tests in the previous phase 2 data from the Maestro-NAFLD trial or the OLE trial and the phase 3 data. So all of them are showing consistent signals of improvement. There's an improvement in atherogenic lipid profile, not just LDL-C, but also apolipoprotein B and lipoprotein A, which tells us that there may be a potential for cardiovascular benefit, which the future will tell us. There's improvement of quality of life. The effect is independent of baseline body weight or diabetes status. It is neutral to weight loss and glycemic improvement. So this might be an ideal drug for those MASLD patients who do not have diabetes and who are not obese. There are no severe adverse effects that have been reported. This point, I think, is very, very important, that this is an oral drug, unlike, say, the injectable Semaglutide or the Tirzepatide, etc. And so the compliance with an oral medication is likely to be much more. It is already FDA approved, not approved as yet by DCGI. It is not available in India, but can be available through a compassionate program. And it could be gotten imported into India, and the cost per month would be only around 4,000 to 5,000 rupees, which for an injectable Semaglutide or Tirzepatide could be anywhere between 15,000 to 13,000 rupees. So my take, first and foremost, everybody doesn't need pharmacotherapy. The vast majority of patients with MASLD will not have significant fibrosis, and irrespective of the cardiometabolic risk factor, there is no role of pharmacotherapy in these patients. Apart from that, I think the choice of the pharmacotherapy would depend on what cardiometabolic risk factors the patient has and what is the stage of fibrosis. So in patients with F2, F3 fibrosis who are non-obese, non-diabetic, it's definitely, I believe that Resmetirom should definitely be a first-line therapy. In patients who are obese or diabetes mellitus, possibly it could be an add-on to a GLP-1 or GIP or SGLT2 or whatever. But I think we need to decide about upfront combination in the future. Thank you.
Thank you, Dr. Arkan. Now it's turn of GLP-1, which will be delivered by Dr. Rakhi Maiwal.
Thank you, Aroda sir, Dr. Ashish, and Dr. Praveen for giving me an opportunity to take on this debate. And it's a very interesting debate because we're debating different drugs as a first-line pharmacotherapy. So how I would start by debating is what Arka had said in his last slide is that if you look at all the guidelines, the pharmacotherapy is indicated, the first-line management for MASLD for all stages is lifestyle. And you look at the second recommendation, weight loss. So that is what we need to do. And 80% of our MASLD population is obese. The pharmacotherapy is not indicated for all, but the fibrotic group, and we divide that as the intermediate or high-risk groups. So cirrhosis is also considered a population where you may need treatment. The cardiovascular risk reduction and therefore the liver-specific effects of resmetirom. So we need to see, we have to have a holistic care and also look at, and like the beautiful talks by the previous speakers have told about the risk of cardiovascular events in these young patients with MASLD. So you have to have drugs which take care of all these problems in these patients. Now, lifestyle is very good, but we see that the compliance is only seen in 10%. So obviously, we have to ask our patients to do lifestyle interventions, but that does not help the majority of the population. And we also listen that most of the problem is also about overnutrition. So the satiety center has to be handled, and the satiety will also improve the outcomes of these patients. So this is a very beautiful review just come up in NEJM. And what I just wanted to highlight, if you have to make a diagnosis of MASLD, you need to have one of the metabolic risk factors. So these risk factors will include either obesity, diabetes, hypertension, or your dyslipidemias. And when you look at the increase in the risk of new onset adverse clinical events, even if the patient is not having diabetes at baseline, no cardiovascular event, the patients do develop chronic kidney disease and other organ involvement. And we can see the odds ratio varies from 1.5 to 2. And all the other systems are also important in these patients. And we're not just treating liver, we need to take care of our patients as a holistic goal. So when you look at the physiological functions of the GLP-1 analogs, so we're talking about Semaglutide, and my colleague will talk about Tirzepatide. So both of these GLP-1 analogs have shown immense data, and by acting on the satiety center in the nucleus of Tractus solitarius, they cause a decrease in the appetite. At the level of the pancreas, they cause a decrease in the islet cell proliferation, decrease in the apoptosis. And what happens is there is a decrease in the glucagon release and increase in the insulin release. There is also a decrease in the gastric emptying and other organs, which I've just shown in this cartoon. There is immense data of GLP-1 analogs, not only improving the NASH population, but also they act on different organs. And particularly, even there is data to show that they even improve the bone health, the joint health, which we also see very commonly in this set of patients. So because we are in the evidence-based medicine world, so we have to talk about the evidence. So let's look at the evidence. We have the evidence from phase 2B for the semaglutide, and this is a large trial which looked at the benefits of semaglutide in population of NASH, which was all biopsy proven, and a resolution of NASH with no worsening of liver fibrosis was seen with different dosages, and also an improvement in liver fibrosis stage was not seen in the initial trial, but now we have the largest, the Essence trial, which is the phase 3 trial, and this trial was conducted around 253 clinical sites, 37 countries, 1/3 of the Asian population. A lot of centers from India were also included in this study. And this trial was a double-blind, placebo-controlled, and they looked at the comparison of 534 patients who were treated with once weekly semaglutide at a dose of 2.4 milligram or placebo. And they did an interim analysis, and the 72 weeks data of the interim analysis has been presented here. And we can see here that there was an improvement in the outcomes by almost in this population, and both reduction in fibrosis and NASH resolution was seen. And the indirect surrogates like the ELF score and in the semaglutide as well as the fibroscan also showed reduction in almost 50%. We are concerned about the adverse events, but if we see here, the adverse events was seen in majority, but it was equally matched with the placebo. And what we are actually discussing and problem is the serious adverse or the fatal cardiac events. So in this large cohort of patients, only less than 1% were shown to have the adverse event. Now, we know that diabetes is the most important risk factor in the MASLD population. And this is how the diabetes and the liver societies have now get together. And to say that you should not forget screening even for liver disease in the diabetic population, because that was not initially that was recommended, because every 2 in 3 patients of diabetes have MASLD. Because we're discussing GLP-1 analogs, and we can see here, considering this, the patients who have both diabetes and MASLD, GLP-1 have been recommended even by the American Diabetes Association as a first-line management. So even above Tirzepatide based on the data, and you can see here the comparison with Tirzepatide, because we can see here the data is very strong with respect to NASH, and obviously in the reduction of the vascular events, the CKD, all other, the data for Semaglutide is stronger than Tirzepatide. On cardiovascular outcomes, this is a very recent systematic review and meta-analysis which showed a benefit of GLP-1. ARCA was talking about this complication, and this is a very serious complication, but why? It is most often seen in poorly diabetic controlled patients, and most of our trials of NASH, we did not include these populations, so that is why maybe it has not been reported. So we have to be very careful while we're selecting our patients for these drugs. This is a comparison of how we can compare the 4 drugs which we have as of now. So GLP-1 analogs, I showed you the comparison of Semaglutide and Tirzepatide, similar in many aspects, but the data for NASH is much stronger for Semaglutide. When we compare Resmetirom, Resmetirom and Semaglutide are the only 2 FDA-approved drugs, but we can look at, I know there is no head-to-head trial, but the data from the trials which have shown the efficacy of Semaglutide is 62% compared to 34%, but it was much lower. I know we should not be comparing, but the population of NASH patients, similar biopsy proven, this was the efficacy. And when you look at the systemic effects, so the benefits of Resmetirom, if we compare with GLP-1, are not seen in the other complications that we're talking about, which are also present in this population. PPAR, yes, there is data. Again, we don't have phase 3 data. And obviously, many patients do get weight gain. And there is also data of pioglitazone causing poor, cardiac retention, fluid retention. So that I do not know. We need to look for more data. Cirrhotic population, very clear. Resmetirom should not be given. Very thin line between F3 and F4. So again, we have to be very cautious in dealing with the advanced set of patients when we're treating with the GLP-1 or with Resmetirom. So I would like to say that if we see here, taking out the data for the lean population and Asian population, overall, in the majority, 80%, as of now, GLP analogs will look like as the first line of pharmacotherapy. Thank you.
Thank you, Dr. Rakhi. Now the 5th drug, that is Tirzepatide. Dr. Manav is going to tell about it.
Thank you, Ashish. Thank you, Dr. Arora. So there must be a reason why the organizer, Ashish, has asked me to take the last word. So last drug I'm going to talk about, I'll start from the last slide of ARCA. See, ARCA wrote a obituary for PPARs. He said they don't work. SGLT2 also, he said, it's a useful drug for diabetes control, but it has no direct action on liver. It does improve steatosis and fibrosis, but by controlling diabetes, not by a direct action. Then he talked about Resmetirom, which he told us that it's a first-line drug to be used for a non-diabetic, non-obese patient, which is 10% of your population. So what do you do for the rest 90%? Rakhi very eloquently told us Semaglutide is the drug to use. Now, as an individual, Rakhi and Manav may be very good, but when they join together and work together, it may be better. This is exactly what Tirzepatide does over Semaglutide. Let me take you through the data. She told you where everywhere the organs where Semaglutide acts, and absolutely agreed with her. It's a very good drug to use. What Tirzepatide does is it adds one more receptor agonism in addition to the GLP. So there's a receptor called glucose-dependent insulinotropic peptide. What it does is it enhances the action of a GLP receptor agonist on adipose tissue by increasing insulin sensitivity, improves the action on the hepatic tissue itself, causes more appetite suppression by acting on the CNS, and further insulin secretion and inhibition of glucagon in addition to GLP-1. So it has a synergistic action over GLP-1 receptor agonist, and the results will show why it may be better than semaglutide. Of course, when you have more action, you have more receptors which are being agonistic effect is being given, you have more side effects also. So you have more loss of appetite, you have more nausea, you have some vomitings. But I guess that is what is required for weight loss and diabetes control, and that's where it scores. I'll take you through the story of Tirzepatide. The initial trial, I'll only talk about randomized control trial or a very large cohort studies in this presentation. So started with the SURPASS-3 trial. We know SURPASS-3 trial is the Batman of all diabetes, obese patients, sugar control trials regarding GLP-1 receptor agonists. Almost 2,000 patients were recruited, and a sidekick of that Batman, Robin, was SURPASS-3 sub-study, which I'm going to quote here. 296 patients, all insulin naive. They were randomized to 4 groups, 1:1:1, Tirzepatide 5, 10, and 15 milligram versus placebo. And what they did was they measured liver fat content, visceral adipose tissue volume, and subcutaneous adipose tissue volume by MR-PDFF and MRI of the whole body. Estimated treatment difference. If you look at the absolute liver fat content change, it was almost 8% in the Tirzepatide arm versus placebo only 3%. Relative change was to the tune of 50% in the Tirzepatide arm as compared to only 11% in the patients who were on insulin in comparison to Tirzepatide. Similarly, the adiposity, the subcutaneous adiposity as well as the visceral adiposity was much lower in the patients who were on Tirzepatide. Naturally, this is a non-biopsy based study only on MR-PDFF. This was followed by a biopsy based randomized control trial in patients with MASH with or without diabetes. Total 190 participants with F2 or F3 fibrosis, of which they had 157 liver biopsies. Again, randomization is same. 5, 10, 15 milligram weekly Tirzepatide versus placebo. Duration was 52 weeks. And what they looked at was the standard MASH endpoints. Primary endpoint was resolution of MASH without worsening of fibrosis. Secondary endpoint was improvement of at least one stage of fibrosis without worsening of MASH. And look at the results. Arrow is here, yeah. So 62% resolution of MASH without worsening of fibrosis in the Tirzepatide arm compared to 10% in the placebo arm, and the difference was statistically significant. Similarly, they showed almost a 25% reduction in fibrosis over the placebo arm. Now, this did not reach significance because of the type 2 error. It was not the power of the study. The number of patients are not good enough to show the difference, but you look at the delta. The delta Rakhi quoted, the delta, that means the fibrosis difference between the intervention arm versus the placebo arm, Rakhi quoted was 14%. But the number of patients here are much more, 500 in that study. Here, the delta is 25%. It may not be significant. Why? Because the number of patients is lower, but it is likely to work more by fibrosis reduction as compared to semaglutide. AST, ALT level as expected came down to normal in all 3 groups of Tirzepatide. If you look at liver fat content, 50% reduction in fat. Look at liver stiffness, 3 points reduction in LSM as measured by FibroScan. So, patients with MASH with moderate or severe fibrosis, treatment with Tirzepatide for 52 weeks was more effective than placebo with respect to resolution of MASH without worsening of fibrosis. The results of fibrosis would be confirmed subsequently once we have a larger number of patients. This is what is published last month. Same trial, a different way to analyze. 190 participants, all taken and divided into 34 post-hoc groups, which were divided by demographics, histology, serum and imaging biomarkers. And look at this. Here the red bar you see is the risk difference 0. Anything which crosses the red bar on the left is not significant. On the right is significant difference. So no matter how you categorize your patients, whether you categorize by sex, by age, by BMI, by fibrosis, by liver fat content, by AST, ALT levels, Tirzepatide is definitely better as compared to placebo in all groups. How about direct comparison of Tirzepatide to semaglutide? You don't have direct comparison as in the liver endpoints, but you do have obesity endpoints. There are randomized control trial published comparing these two drugs vis-a-vis weight loss. I am just quoting two of these studies. This one is a publication of this year, 6 months back, in patients with obesity without diabetes. Look at the difference, 20% weight reduction in patients who have obesity without diabetes with Tirzepatide compared to 13% with Sema. We understand obesity is a risk factor. We also know more the weight loss, the better is liver histology improvement. Tirzepatide scores significantly over Semaglutide in weight reduction. It should score significantly as compared to liver histology also. Look at 10% reduction, 15% reduction, 25% reduction. Every single subgroup, Tirzepatide scores over Semaglutide in weight reduction. By corollary, it should score over histology reduction also. We have seen the initial in the Synergy-NASH trial. We'll wait for the more data to be published before I can give you that with conclusion. What happens if the patient has obesity with diabetes? Similar results. This is a cohort study, 18,386 patients. Again, similar thing is repeated. More than 5% weight loss, more than 80% of patient in Tirzepatide versus only 65%, not only, 65% is also significant, but 82% is more than 65% in Semaglutide, right? Even in 15% weight loss, Tirzepatide scores over Semaglutide even in real world study. This is 18,000 real world patients. If you compare diabetics with non-diabetics, the weight loss is slightly more in non-diabetics, but even in diabetics, it scores over Semaglutide. In my opinion, do we have 30 more seconds, sir? Okay, so this is published last month. This is something where they took all the drugs which are available for MASH and ranked them by something what you call surface under cumulative ranking curve. It's a type of ROC curve which they make and try to compare which drug is giving the maximum benefit. And they took everything which you have under the horizon, took only RCTs, 29 randomized control trials were taken in this. And this is what we get. What they did was they plotted the risk ratio of each of these drugs. Again, the same thing. What you see is this line is 1. Anything which crosses the line on the left side is not significant. Everything on the right is significant. The more to the right, the better the drug is. Look at Semaglutide by the red arrow. Look at Tirzepatide. Much more on the right side. So the effect, the risk ratio of improvement of NASH is more with Tirzepatide compared to Semaglutide when you talk about MASH resolution. When you talk about fibrosis, the results are not so apparent, but still the Tirzepatide dot is slightly on the right side as compared to Semaglutide. So this is a ranking they have shown. Tirzepatide is above Semaglutide in fibrosis improvement. Tirzepatide is above Semaglutide in MASH resolution without fibrosis improvement. I think I'll rest my case here by saying that Tirzepatide leads to resolution of MASH as well as improvement in fibrosis in patients with F2, F3 fibrosis. The weight loss and fat loss is much more